Welcome to this edition of Prime News. I'm Dr. Lee Lokey, and I'm joined by my colleague, Dr. Janice Galleshaw. We're here, Jan, in a rather cool, cloudy, rainy New Orleans for the 55th annual ASH annual meeting.
Yes.
It's been an interesting meeting with a lot of new data and a lot of very encouraging data.
It's been very exciting. Some new things coming out that I think our practice changing as we move through this.
Agree.
Mm-hmm.
We've just left the plenary session, which included two abstracts that I think we both think may well be practice changing. And I think it would be helpful for our viewers to hear about these two and at least get our take on the data that was presented. Mm-hmm. The first of these is a very interesting trial in newly diagnosed multiple myeloma in patients who are either over 65 years of age or ineligible for a stem cell transplant. Tell us a little bit about that study.
Yes, this trial it has several different names. The first trial is the easiest one to remember. Some will know it by the MM020 or the IFM0701. It's all the same study. And as you said, it was to look at patients who are not transplant candidates, newly diagnosed multiple myeloma, and examining whether or not lenalidomide might be able to play a role in improving outcomes there. And Dr. Thierry Fesson from Lille, France, was the presenter on this. The trial design basically, there were three arms. Two of them had lenalidomide in it. Arm A had lenalidomide plus a low dose of dexamethasone that was given continuously. Arm B, on the other hand, had lenalidomide plus dexamethasone for a fixed period of time. It was 72 weeks, which is the equivalent of 18 cycles. And then Arm 3 was the standard MPT, the melphalan, prednisone, and thalidomide, again for 72 weeks, which is 12 cycles for that regimen. This was a very large trial. It had over 1,600 patients, and 18 countries were enrolling patients on the trial. And the primary endpoint on the study was progression-free survival. There were several secondary endpoints, and a lot of them actually, including overall survival, response rate, duration of response, time to progression, and so forth. But when it comes to actually looking at the data, the enrollment on the study, the average age was 73 years of age, so it was clearly an older population, and the median follow-up was 3 years. They looked at some specific subsets, and those who had high-risk cytogenetics represented about 20% of the patients in the study. So the primary endpoint, progression-free survival, clearly was in favor of the lenalidomide continuous arm as compared with the fixed lenalidomide or the MPT arm. Specifically, the progression-free survival was 25 months. The other two arms were more like 21 months each. They also looked at the 4-year overall survival in the patients who were on study, and again, the continuous lenalidomide arm was superior to both the other two. 59% had a 4-year overall survival. And all the other subsets that they examined favored lenalidomide.
Mm-hmm. So what about toxicity?
Well, that's I think what everybody wants to know about, because clearly there are differences in these regimens. And when we looked at the MPT arm, it had more, the melphalan-containing arm had more hematologic toxicity. It also had greater sensory neuropathy, and finally, secondary hematologic malignancies were greater in the MPT arm. So the lenalidomide arm, on the other hand, they had a greater incidence of infections, so it was more myelosuppressive. But it was felt that those were manageable toxicities, and clearly I think lenalidomide comes out of this looking like a new option for our kind of unfit elderly patients in the first-line setting.
So did the introducer imply that this was a new standard of care?
Well, you know, it's interesting the way they did it, because in the whole plenary session, the introducers came up and gave a little talk before the actual presenter did. And in this case, the introducer was Dr. Jesus San Miguel, and he wasn't as, I think he didn't feel like the right comparator had been done, because he went back and talked about historically initial therapy for patients with multiple myeloma who were not fit for stem cell transplant had been melphalan and prednisone for years. And then more recent studies have demonstrated if you add either thalidomide or bortezomib, you can improve survival. But lenalidomide has demonstrated improved progression-free survival, but never an improvement in overall survival. So I think that, I'm not sure where he was leading with it, but he kind of set the stage before the presenter. But nonetheless, I think lenalidomide and this really sound quite impressive in terms of achieving superior outcomes.
Good, good.
Now you, on the other...
Interestingly, Dr. Jesus San Miguel's colleague had, in a educational session, indicated that she thought this was going to be a new standard of care.
Well, I'm not surprised by that at all. You know, it was interesting because another of the abstracts that we're going to talk about is looking at a different disease, CLL, but again, it's for the older patient population, not the group that we are used to seeing enrolled on clinical trials typically. So why don't you tell us about what you learned there?
Yes, this abstract number 6 in the plenary session was really a very, very interesting study looking, as you say, at patients with significant comorbidities. This was the German CLL 11 trial. And the trial is quite interesting because it basically, this portion of the study examined the head-to-head comparison of rituximab and chlorambucil versus GA101 or obinutuzumab and chlorambucil. So it's a bit interesting in that the companion cytotoxic therapy chosen was chlorambucil rather than the more commonly utilized FC in the FCR regimen. So there have been a number of comments about that choice. But perhaps for this group of patients, this may be ultimately a very interesting and very effective choice. Mm-hmm. But the primary endpoint here was progression-free survival with response rate, minimal residual disease, and overall survival as secondary endpoints. The primary endpoint was very easily met in this group of patients. It was clearly superior for the obinutuzumab arm versus the rituximab arm. The secondary endpoints, response rate and minimal residual disease, also significantly improved with the obinutuzumab versus rituximab combination. Overall survival did not meet the preset boundary. But there appears to be, at this point in the follow-up, a trend toward an overall survival advantage for the obinutuzumab arm. So we had a very interesting introduction to this abstract by Dr. John Gribben, mm-hmm. And Dr. Gribben felt that this probably did represent, at the very least, a new control for future studies in the unfit patient population. And interestingly, these patients in this trial had an average of 3 comorbidities based upon the way that the German CLL group analyzes comorbidities. Mm-hmm. They have a go-go category, a slow-go, and a no-go category. So it's a very...
Keeps it simple, doesn't it?
It's a very practical classification
right.
scheme, yeah.
Well, you know, the other thing that he pointed out, which I think is so important, is historically trials haven't looked at our elderly patients. They would be excluded. Not only did this trial specifically seek them out, but there was some skepticism about the ability to accrue patients to this trial, and apparently it was very rapidly accrued.
Extremely rapidly accrued, and I think one other point that was worth making is that it is felt by these investigators that achieving a CR should be a goal of treatment, even in the elderly, unfit patient population, that doing so results in better ultimate outcomes.
That's exciting. As we're getting older, it's nice to know that we can maybe have a CR someday too.
You bet, you bet. So these were really, I think, Jan, 2 excellent abstracts for the plenary session They were very clinically relevant, and I think, as we've said, potentially practice-changing. So we'd like to thank our viewers and hope that you found this report from the 55th Annual ASH meeting useful.